Hi, everyone. It's my great pleasure to introduce you to the National COVID Cohort Collaborative on behalf of the N3C Consortium. You can find these slides at that link below, and you can find me on Twitter at Antawonka. So why do we need the National COVID Cohort Collaborative, or N3C? Well, the reality is that in the United States, the fragmentation of COVID-19 patient clinical data is quite extraordinary. Different patients see different providers in different locations. These locations are not connected. Furthermore, patients move around, and it's very hard to track the longitudinal trajectory of any given individual patient. Furthermore, because there is no centralized healthcare in the United States, there is also no centralized healthcare data. And therefore, it makes it very hard in the context of a pandemic to actually have enough data to do the kinds of analytics that would be helpful to understand the disease progression and how we might prevent the worst outcomes. Fundamentally, this problem is more than just COVID or any given pandemic. We need to do a better job worldwide of going from practice-based evidence to evidence-based practice. So a patient has encounters, they produce with their clinical provider, they produce data that ends up in a clinical warehouse. That clinical warehouse data is then used to populate registries and data marts from which we can create inference or medical knowledge that we then use and we manage that knowledge and share that knowledge in the form of knowledge bases, clinical care guidelines, and delivery into expert systems for clinical decision support during the next patient encounter. But for this virtuous cycle to take place, we fundamentally need comparable and consistent data across all the different parts of the life cycle, and the data needs to be harmonized in order to make all of the life cycle complete. One of the challenges that we have in doing that is that mapping data is all over the place. It's lossy and it lacks a lot of the provenance that would actually help us troubleshoot when things are lossy. So for example, we have source terminologies such as the International Classification of Diseases, or ICD, SNOMED CT, and many other clinical terminologies that are often mapped to one another. We have resources such as ODSSS, or the UMLS, or the National Cancer Institute's NCIT or EVS vocabulary services that all provide mappings between these different terminologies. And then we have coded data at local institutions where the locally coded data is transformed into one of these source terminologies, potentially using one of the mappers, or uncoded data that needs to be coded and transformed into coded data. And then fundamentally, then we have code sets, which are collections of terms that are used to mean the same thing in different contexts. So for example, all the different terminological codes that would be used to represent a positive COVID-19 test. So federated and centralized approaches can be synergistic. Most clinical research networks have traditionally operated as federated networks, where one can ask specific types of queries where the clinical data lives behind the firewall. So for example, how is time on the ventilator impacted by a given drug? That question would be sent to all the different data partners. They would run the queries, and then the results would be aggregated and sent back, either using an average or some statistical model for understanding the distribution across all of the different sites and all the patients within those sites. This is not a very good environment for doing more modern AI and machine learning types of approaches where we have more discovery-oriented questions, such as in patients under 60, which factors are most predictive of severe outcomes. And so in the context of the pandemic, we really needed a way to centralize the data. And it was synergistic with the federated research networks because we could build upon their incredible work that they had done already and work together in order to create the centralized repository. So the National COVID Cohort Collaborative is now the largest publicly available HIPAA-limited dataset in U.S. history, with over 20 million patient records from over 230 different clinical institutions. It's representative, both in terms of demographics, as well as socioeconomic status and health backgrounds. The data is harmonized. It overcomes much of the source heterogeneity. I'll get to that in a minute. The data is linked to many other different data sources and can be used for public health surveillance, whether that's for looking at new variants or comparative effectiveness of specific drugs. What we did was we worked with those different research networks, the ACT network, the Trinetics network, the PCORNet network, and the ODSSS network, which produces OMOP, as well as several others, smaller ones, in order to harmonize those data create a computable phenotype and acquire the data from those over 200 sites, harmonize those data, and then make that available in a collaborative environment that's secure and hosted by NIH. We now have over 450 organizations participating with approximately 5,000 users using the data. So ensuring harmonization rigor with scalable continuous monitoring and provenance was one of our major goals, given all of the mapping that goes on. And so what's shown on the bottom is just one mapping pipeline where we have complete transparency into the lineage and provenance of harmonizing that data from just the one site. And then this can be repeated, of course, for every site. And this is over 50,000 different transforms that are captured. The pipeline is fully versioned, deployed, upgradable, and automated in terms of data quality checks of new and existing sites, and curators and developers can quickly identify and address issues. The scalability of these compute resources is also important. These pipelines can be refreshed in approximately 20 minutes. We also built some really innovative governance structures to allow us to continue to grow and scale the resource. Specifically, this was a public-private government partnership where the three sort of tripartite strategy was to really work together to come up with what the data use agreements would be, the data transfer agreements, codes of conduct, attribution policies, and the IRB protocols. This allows us to have shared governance over the original data transfers, the creation of the harmonized data set and its distribution into a HIPAA-limited data set tier, which requires an IRB protocol to access, a de-identified data tier, which requires only human subjects training and security training, as well as your institution's data use agreement, and a synthetic data tier that we're currently having expert determination on in order to make that data downloadable and fully available. It's important to remember that harmonized does not mean homogeneous. The different source common data models have very different expressivity, include different things. So for example, the Odyssey community in their OMAP model requires a death date. So if a patient has passed away, that would be required to be recorded, whereas COREnet does not require that a death date be recorded if a patient has passed away. So it's important to keep these differences in mind so that when you're analyzing data, just because you don't see a death date does not mean then that you can guarantee that that patient is still alive, for example. One of the great things that we've learned in this process is that by centralizing data, we can really advance the way in which we think about data quality. So this is just showing the distribution across 16 of our sites, looking at positive or negative COVID tests and the different codes that are used for those tests. And so you can see that different sites are using different codes to represent essentially the same thing, that you have a negative or a positive COVID test. And so reconciling these differences is really important. We also do a lot of other kinds of quality assurance checks, such as, for example, looking at the number of COVID tests and the positive versus negative proportions, the average number of rows of data per patient, plausible demographic distributions, and visits with negative lengths. So if you end up in the hospital and you depart the hospital before you even got there, then there's clearly something wrong in the data. We were also able to repair the data in some cases. So this is an example for units where humans that are measured in grams, for example, do not look the same as humans measured in kilograms. And it's surprising how much this happens. Specifically, if you look on the right, the green bars are the proper units for a variety of different clinical labs and their measurements shown on the y-axis. And the blue bars are the ones that we can algorithmically repair by transforming either a missing unit based upon the range, or transforming existing units that are not the standard unit for that lab. And so we can repair quite a large amount of data by providing these rules and algorithms for data repair and make those data available for analyses. The N3C was able to provide the earliest and most representative data to predict risk and inform health policy in the United States. Again, remembering that we did not have centralized healthcare, so no centralized healthcare data. We were able to examine the conflicting research on the effects of vaccination on long COVID, determining who is vaccinated in the United States is quite challenging. So working with states and institutions that had very good quality vaccine data, we were able to provide two different approaches to examining the risk of long COVID, whether if you had been vaccinated or not. And so this reconciliation of vaccination data was able to demonstrate that, in fact, vaccination does reduce the risk of long COVID. Similarly, when Paxlovid was first available, our United States White House wanted to know whether or not it was effective. And we were able to show that few patients required care or were hospitalized post-COVID following Paxlovid treatment, and that it was, in fact, effective in the early real-world data. We were also able to create the first evidence-based definition of long COVID using machine learning. So this basically identifies people with long COVID before they are actually diagnosed. So we trained this machine learning phenotype using either patients that had been seen at a long COVID clinic, or if they had been coded with the newly available U09.9 long COVID code. We learned the patterns of clinical features, and thereby we're able to identify previously unknown cases using these learned patterns. And this was critically important given the fuzziness that has existed in defining long COVID, and provides an ability to identify cohorts for study recruitment as well as for treatment considerations. So what we learned from this machine learning definition, we were able to identify using sensitivity analyses to determine which factors were most important in predicting someone as maybe having long COVID, such as difficulty breathing being associated with a higher risk of long COVID, or vaccination being associated with the lower risk. And in this context, we were able to identify almost 140,000 adult long COVID patients, which is approximately 8% with high confidence, who may be eligible for our United States Recover interventional studies. We've also done a lot of work on subclassifying long COVID in order to understand categories of patients, given the incredible spectrum of phenotypic features that we see in long COVID patients. And so it's been a great data set for really exploring and working together to create these different classification strategies for long COVID. So I wanted to talk about putting the patient back together again. As I mentioned, patients visit different clinics. They also have many different data streams, and it's very hard to garner a complete picture of their health and their illness. And so we work together with the National Institute of Health, as well as many public data sources to integrate many different public data sets. So for example, we have air quality, environmental health data, the Environmental Justice Index, EPA Social Vulnerability Index, and many other different data sets that are available now together with the electronic health record data in the N3C. So the EHR data is necessary, but it's not sufficient. We also can do something called patient privacy preserving record linkage, which allows us to deduplicate records. So if Jane Doe is seen at two different clinical institutions, we can link those records and know that it's the same person. But we can also link it to Jane Doe's other data. So for example, her social determinants of health data, any viral variant data that might have been associated with her and shipped off to one of the genomic repositories, mortality data, vaccine data, imaging data, and registries. And working together with Datavant and the Regenstrief Institute as our honest broker, we were able to do this while preserving privacy for the patients and reducing risk of re-identification and keeping the data secure. We're also really invested in provenance, transparency, attribution, and rapid sharing. So essentially, because the N3C enclave is so highly secure, it also allows us to understand everyone who contributes to anything. And so all researchers, projects, and artifacts are linked together with a full ontology in the enclave, allowing us to understand who should be attributed for any given outcome. And the artifacts are all associated with ORCID identifiers. And this provenance graph shown on the right allows us to understand how to ensure transparency and reproducibility of a full end-to-end pipeline, so that when you go to publish your paper, you can know that the pipeline can be visited by a reviewer and be fully reproducible. This was really especially important in the early part of the pandemic, where a lot of observational research on clinical data was not readily available. The impact of this program has been extraordinary. We have over 2,500 citations with an H-index of 24 in just over 2 years. This is an incredible amount of collaboration and productivity by the scientific community, and really speaks to the utility of these data and the data sharing that went on in the United States to help combat the pandemic. We have not only had this incredible scholarly productivity, we've been able to provide attribution at scale and really incentivize collaboration so that people build on each other's work and do better science, write more papers, and get science done faster and better. We've transformed care guidelines and developed an evidence-based disease definition of long COVID, as well as complex risk prediction models.
It has been an incredible honor to be a member of the international team collaborating on COVID research in solid organ transplant recipients. This work has informed decision-making for Canadian transplant nephrologists and multi-organ transplant programs alike.
The patient is the most important factor in research, and N3C provides an opportunity to amplify our voices and provide valuable insights on the long COVID community research efforts.
So I'd urge you to go and see the rest of the video. It's really an incredible video put together for our DataWorks prize. And I'll tell you about that in a minute. There's just an incredibly large number of people who have contributed to this work, and it's really wonderful to hear their voices. We published the first marker paper in JAMIA. JAMIA had never had a paper with 199 authors on it, and it took them quite some time to get all of the authors indexed in Medline. So we believe that we have really transformed clinical informatics into something that's more collaborative, akin to the genomics community a few decades ago. So as I mentioned, we have won the grand prize in the NIH FASTEV DataWorks competition for democratizing access to sensitive clinical data. There were 106 teams represented for this prize, with 26 countries represented. And so we're very, very proud of this, and the money will be spent back on the community. So you can participate too. If you go to this link, covid.cd2h.org/onboard, there's all kinds of information about how to get an account and how to access the data, how to join domain teams to find partners that can help you get to know the data, get to know what's been done, what needs doing, and find partners to do the kind of science that you might be interested in. And with that, I'll take some questions. Thank you very much.